this is my dad, Dr. Hernandez. He's a cardiologist. He did pre-med at UM and then went to Puerto Rico for medical school. And then for residency, he went to Mount Sinai in New York and then went to Florida. Did I get that right?
Oh, a little bit.
Okay, well, the floor is yours, so.
Thank you, appreciate it. Thank you for having me. Well, I'm a cardiologist. What entitles to be a cardiologist and how do you get here? You have to do your 4 years of college. Then I did my 4 years of medical school, 4 years of, well, 4 years of medical school, University of Miami. And from there went to Mount Sinai, New York, where you have to do your 3 years of internal medicine in order to do a subspecialty. Did that. Then I did pulmonary critical care. Then went to St. Vincent's Medical Center to do 3 years of cardiology. So it's 9 years of training. And been in Florida since 2008. So thank you for having me. I want to speak and show you guys what are the updates that we have in cardiology today. It's a field that is changing a lot to a lot of interventions and fixing things through catheter instead of opening the chest. So we're going to talk about some innovations that we have in cardiology. I teach residents, I teach fellows, I travel, speak for companies, conventions. So this is my first time speaking to students. So try to tone it down so you guys have an understanding. Pretty much the last time I spoke to students was here, which is when my daughter told me to speak at in kindergarten class. So thank you for having me. Okay? So this is pretty much a cardiac suite looks like, okay? Which is in my office, which is an opinion center consisting of a table, pretty much a surgical table, and pretty much we have a machine which uses a C-arm moves. Remember, the heart is a three-dimensional structure, so you got to move around and take pictures from different views, inject and dye. So how do we do that? So as you can see, I brought catheters. I wanted to show you. What do we access? When you guys touch here in your groin area and you feel your pulse, that's the common femoral artery. So that's what I'm trying to access. And there's a mnemonic called VAN, vein, artery, nerve. From medial to lateral is vein, artery, nerve. You try to obviously hit, you know when you hit the nerve, when the patient goes, ow, and you're like, oh, it's okay. And then you go move a little medial. Well, this is the catheter that I access the common femoral artery. Okay, through a sheath. It's that big. And the wire that goes through. Okay? So you guys can pass it around. So pretty much when through that catheter I access the groin, and then through a set of wire systems, through these wires I pretty much use these catheters that go all the way from the groin all the way to the heart, and as you can see they're already preformed. Meaning this is meant to get into the ventricle. You see the shapes. This is meant to hook up to the left main so I can look at the left side of the heart. And then this is actually pre-made to look at the right coronary artery. Okay? And this is accessed through a set of wiring systems. And you should pass around. So going over pretty much what we do, have an assistant and through fluoroscopy and contrast, and able to manipulate the vessels. So to review normal coronary anatomy, which have a nice displays, and actually I can use this, which is great. So as you know, if we have the right coronary artery that runs from a different side of the aorta and the left coronary artery. Left coronary artery gives up the left main artery gives up the left anterior descending artery, gives up the circumflex artery that divides into the obtuse marginal artery. As you can see, this is what I want to see. I want to see nice garden hose, lean arteries. Okay? When we have coronary artery disease, I'm going to show you, it looks like someone stepping on garden hoses. So this is again another view, and you can see how the left anterior descending artery, nice and smooth all the way to the apex. Left circumflex artery, nice giving the obtuse marginal artery from different angles. With me so far? Okay. So again, a different view, and then here we're going to see more in a live approach. So as I inject dye, you can see how it slowly fills, and I'm looking for indentations on them. Again, nice and smooth. Follow me? Nice and smooth, which is what we want. Okay, this is now through the other catheter, the right coronary artery cannulate, and pretty much you see how nice and smooth the right coronary artery along bifurcates into the posterior descending artery and the PLV, posterior ventricular. This artery is important because this is, remember, the right coronary artery supplies the conduction system of the heart. So when you have blockages in this artery, patient presents with heart block and arrhythmias. So coronary artery disease. To better explain, I brought this model we can pass around. Actually, I think I put a picture. Yes. So, because it's like, how does it form and actually what is it? So you have a normal coronary, and as cholesterol builds up, secondary diet, diabetes, smoking, it builds up in the walls of the heart. It is not actually in the inside. So the heart has the intima, the media, and the externa. So between the media, plaques building up, and usually when it gets up to here, less than 50% of the radius, patient develops chest pain, and we can actually set these patients for cardiac cath and catch it early. What we want to prevent is when what happened is when it bursts. Because when it bursts, what happened? Same as when you guys cut yourself, you watch the blood go out, and then all of a sudden, blood stops because platelets adhere and stop the bleeding. So for the heart, it happens the same. So for the heart, what happens? If it occludes, it creates total occlusion obstruction, and then subsequently heart attack and muscle damage in the other side. So here, for example, in angiograms, you can see very different. Look what happened here. This is the left anterior descending artery. It's pretty much, you can see less than half the radius, pretty much a little more than half, so it's a 78% stenosis. So this was caught early, one vessel, so we can come here and deploy a stent. Here, for example, a severe case. When we have one vessel, two vessels, we can put a stent here or there. But when we have 3 blockages or more, or diffuse, that's when you heard that patients need coronary artery bypass, right? Which we'll show you some pictures of that. Look at this one, the left main, look what happened here. 40% blockage, 50, but look at here. Narrowing, 90%, 90%, 90%, so the whole vessel is diffused. The lights can be dim, we'll see better. And you can see here the diagonal also have disease, and you can see also the first diagonal also has 39% stenosis. So see the difference between one and the other? So here's in live version as you see the feeling. Look how severe disease this vessel is. So kind of like common sense, it's hard to pretty much put a full, deploy full stents. So this, you cannot put a stent all the way from mid all the way to distal, so this patient is better served with that coronary artery bypass. Cool, huh? So here's the right coronary artery of the same patient, as you can see, all the way down, 90% blockage right at the bifurcation of the posterior descending artery, which will be here. As it comes out, right coronary artery, and then pretty much your bifurcates in the distal. Okay. I passed those catheters around so you can see the shape. Here's the right coronary artery live. As you can see, 90% blockers, and especially when to bypass. What is bypass? Bypass is pretty much when I take out of the subclavian artery comes out the left internal mammary artery, lima. Okay, so that one we take, detach it from the sternum, and then put it pretty much bypass after the blockage. So we insert it and attach it after the blockage, okay, to fill the corner. But we only have one of them, so where do you get the other ones from? You heard that they take it from the legs. So we take veins from the leg, which is the saphenous, and pretty much invert them, and then we use it as arteries. So we hook it up to the aorta and then bypass the blockages and attach them. Follow me? Okay. So then what happens? Usually these last longer because it's arteries, but I'm taking veins and making it work as arteries. So that's why they say that pretty much the lifelong of this is 20, 30 years. So we have to take care of them. I tell patients always these are patches. We still have to control cholesterol because all I did is pretty much just open the blood flow, but all that cholesterol is still there and it can come back and close up again. So stent. So coronary stents that we have, this is how it looks like. With a mesh, I brought you guys a sample to pass around. And this can stay here for the fluid. I think this is closely somewhere. So as I bypass the blockage, okay, and then I go back, it deploys a stent. Nickel plated. So I wanted to bring you this because I want you to realize exactly what we do, because people, so patients go, oh yeah, it's a solution, I got a stent and it's done. I'm like, it's not done, because all I did is pretty much, well, the model is over there. All I did pretty much is just went through the blockage and I just put a scaffolding. So I just open up the vessels and blood flow can pass. But what happens? All these can come out again and crush my stent. So that's why it's imperative that we can control the risk factors that put us there in the first place. Okay? You want to pass this stent away? It is cool. So here's a deployed stent, and then remember that blockage I showed you at the beginning that someone was stepping on it. So look now after the stent's deployed. Nice feeling, right? What's called telemetry flow afterwards. Peripheral arterial disease, why I bring this up? Just remember, it's not only cardiology, it's cardiovascular medicine, okay? Meaning it's a systemic illness. If you have blockages in your coronaries, likelihood your carotids are blocked, abdominal, legs, so always look for, a diffuse disease. And here's what a peripheral looks like. I passed around one of the catheters, looks like a pigtail. So I go down the distal aorta. This is the distal aorta that bifurcates into the iliac, external iliac, internal iliac. And as it comes to the groin area, when you feel your pulse, that's the common femoral artery. And then it goes to the superficial femoral artery, goes to the knee, which is the popliteal. And then below the knee is the trifurcation. You have to have three vessels, the anterior tibial, the posterior tibial, and the peroneal. So here's an example of a patient that was having claudication, like fatigue. As I go down and see some irregularities, then I'm missing something here. And this is what I'm missing. It's a chronic total occlusion right at the knee, and you can see how it's chronic. The body tried to create collaterals to try to supply the distal leg. This is usually patients that you see with chronic wounds and non-healing wounds. It's because there's no blood flow going to the legs. In the old days, you heard of femoral popliteal bypass, aortofem bypass, and patients had to go to surgery. Cardiology has changed in the year 2000s that now we're able to get catheters and do rotor-rooters, okay? And pretty much now we can actually cross and connect the artery, okay? Through the groin, do rotor-rooter, deploy what you saw right here, just pretty much just cross the lesion, and then back and deploy a stent and post it. So I have an example. Look how severe. Balloon, check the flow, and then afterwards, I avoided this patient's surgery. With me? Questions so far? Okay.
So in that case, the vessel walls are intact enough as long as you open it up.
Correct.
To get the stent.
Yeah. And the reason you leave that wire in first, because you sometimes, remember, you're causing shear forces with a balloon, you can dissect. And it seems to happen in the coronaries. And that's our scariest moment when that happens on the table, patients actually going down, you have to send them, for immediate surgery.
So the artery is is branching really often. So how do you control where the catheter is moving?
Question again?
So because the artery has so many branches, right?
Yes.
The femoral artery branches off in so many places. How do you control if it's like a train track, which way to go?
Good question. Through fluoroscopy. If you see here, as you inject dye, this balloon, you inject dye, you move the wire. You inject dye, you move the wire, and you pretty much, remember, we have a 3-dimensional structure, and we use 2-dimensional mode to take pictures. So we navigate, inject dye, we know our anatomy, and we kind of navigate where the blockage, where it is. So we do it through fluoroscopy and contrast.
And how does this happen in the first place? So that there's the space between the artery.
That has been happening chronically, closing, to the point that because of what happened here. I think I passed the
And
model
so
that I
your
have.
lower leg gets less blood flow, or
Say that again?
does your lower leg get less blood flow due to that, or?
Because of that, yes. Patient starts complaining of leg fatigue. Usually diabetics, they come when I walk, I get it's called claudication. I get muscle fatigue, my leg hurts when I exercise. One feet changing temperature, this is a colder than the other. Or I have a nail that cracked and is non-healing, patient lose their nails, or a wound that is non-healing. There's no blood flow getting to the leg.
And where do you insert that? Do you insert it
Groin.
in the hip, or?
No, groin. Right here, when you touch this area, you're gonna feel your pulse. That's a common femoral. That's where I go all the way to the heart, and I also go down the leg.
Is it common? Or?
It's very common in smokers, diabetic. Those are the most common, and obesity and chronic elevated cholesterol. So pretty much, in order to get to this point, it takes years to develop, and we can get it in time. You can get it in time by doing stress tests and you preventative, and you kind of see, when it's getting to 20-30%. We fix blockages that is 70% or more. Okay, that's when we put stents. 60% or less, you treat medically, because there's evidence that if you treat the patient aggressively with massive medical therapy, there's evidence of plaque regression if you get to those goals in the cholesterol. That answer your question?
Yeah, thank you.
The stent that you're
Yeah.
passing around, that seems huge.
Here,
Is
that's
that-
leg.
That's
For leg. Yeah. If you actually want to know how actually the heart size is, it's your fist. It's pretty much, we operate in a very, very small little gadget. It's really, really the size of your fist, and it's a moving structure. So these catheters, you can see the actual size. Let me pass this through. So here's the question that you had earlier. How do we know? See this wire? I inject dye, I navigate. Okay, I go here. As I inject dye, I start going down where I want to fix.
How do you control which way it goes?
Oh, torque. If you initial picture when you saw there was an operator on the table with a wire that I pass through torque, and it's just down torque, and just up and down, inject dye, pull. Because the wire tip you can see is coiled, so I just navigate, which way I'm gonna go. So remember, there's two legs, so we have to look at the other leg. So you see in these patients, the other leg nice and smooth, no issues. So it's funny with the question that you asked. How do you know this patient only had one leg severe? Look at the other one; it was fine.
Yeah.
So here's a patient with a distal aneurysm. Look at this is all dark, it's all calcium. So calcium is healed plaque over the year. So it's all calcified, it's steady. All here, this is stent that goes all the way from the iliac all the way to the abdominal. And we used to fix aneurysms through surgery, and now we fix them also through the groin.
So in this case, that would be a sign to try to do a preventative intervention to keep from an aneurysm, correct?
Correct. So pacemaker defibrillators. As you know, the heart operates as a car. It has a battery, has cables and wires. So it has a SA node that sends a signal to the AV node to the pretty much the SA node to the AV node to the bundle of his, to the left bundle to the right bundle. And that's why the heart, you see, it goes lub-dub, lub-dub, lub-dub. It's a battery cable, it sends it lub-dub, lub-dub. So what happens? We're getting older, okay? And as we get older, and because either a heart attack or we're getting older, the battery dies. So we're able now today to pretty much replace the conduction system of the heart by a pacemaker. So a pacemaker is just a battery and two wires that I pretty much dial one in. This is the way I asked earlier. How do we put him in? It's a screw. So I go in the same thing with a catheter, but remember, because it's the venous system, I go through the vein, right? And here I put a wire in the atrium, which is going to replace my SA node, one in the ventricle, so I can replace the Purkinje fibers and the bundle of his, and hook it up to a battery and program it. And I brought these pacemakers. You know the difference between a pacemaker and a defibrillator? You heard about it, defibrillators? So pacemaker supplies the conduction system of the heart. And defibrillators are made when the function of the heart is weak, either secondary to a heart attack or a virus, and your ejection fraction less than 30%, these patients are prone to sort of cardiac death. You know, they get ventricular fibrillation, ventricular tachycardia, and it kills you because the heart is not weak, is not strong enough to get you out of the arrhythmia. So these defibrillators constantly detect that, and if it sees it, it shocks you, and it shocks you out of it. And they're bigger, as you can see here. And why did I brought in these little small things? These are loop recorders. Now we used to have these monitors that we check patients 30 days or a 24-hour Holter. You heard of those? And now we want to monitor the patients longer. Now we have these devices that we insert into the skin, last 3 years of battery, and we monitor for arrhythmias. Usually patients that have a stroke and you don't know why it happened, you deploy these loop recorders on the chest wall, and it's a constant EKG machine. I wanted to show you this thing because this is where now technology is. This is a pacemaker. Okay? This is for patients that cannot have surgery, or actually last night I was called a 90-year-old that is complete heart block, and I'm like, I don't want to open a chest in a 90-year-old because it's old, calcified vessel, risk of infection, pneumothorax, I can pay for the lung. So now we have these little pacemakers that we put to the groin and just pretty much hook up to the right ventricle, and it serves as a pacemaker. And then another company that's Abbott got smarter and go like, okay, now we're going to do it in the ventricle, but now we're going to make it also in the atrium, so it's more synchronous rhythm. So you can feel close and pass this out and check them out.
Now, do those two communicate somehow?
Yeah.
To synchronize?
Yeah.
So there's a little bit of obvious technology.
It's amazing. Now everything is wireless, everything Bluetooth. Come to the office, we just put a magnet and kind of like manipulate it. It's fascinating. So here you can see.
When you put the pacemaker in, you have to basically wire it to the nerves.
Say that again?
When you put the pacemaker in, you have to like wire it to the nerves like a catheter.
No, we actually just screw this into the muscle. Right? There's no conduction system anymore, so now I'm gonna control it. So I just put a wire, pretty much bolted in the ventricle, bolted in the atrium, hook it up to the box, and then I program it and I just replace your conduction system. I just paste. The beautiful thing about this is that in order for the battery to last 17 years, I can hook it up to demand, meaning if you're a patient that throws the beats once in a while, the pacemaker detects that and it kind of backs off and lets you throw your own beats. But when it detects that the heart rate goes below 60 or that you don't throw it, you set up an AV delay that goes, okay, hold on a minute, and then it starts firing. So that's why it's called the DD mode, VVI mode. Yeah.
Do the patients notice when the pacemaker?
No, good question. Sometimes when you set the voltage too high, they come and they get like, I get hiccups, I feel it. You're like, oh, okay, and then you tone down the voltage. But you usually don't feel it because it's internal. And the beautiful thing, there's no nerve endings in the heart. That's the good thing. The heart doesn't have nerves, so it doesn't hurt. When the patient goes, my heart hurts, it doesn't. Question? Okay. So we spoke about this earlier. When you heard about patients that have the valves as we age, they can close and become stenotic, and people need aortic valve surgery. So what we have developed through the years now is that we can replace the aortic valve through the groin. And actually we can do it now, we're doing now mitral valves too. And this is what it is. We put a balloon through the groin, we go up, send device, we go to the stenotic valve and pretty much deploy a valve. This is usually for patients that either had bypass in the early years or now they're in the 80s and you don't want to complicate and open their heart again, or they kind of go to surgery because they got COPD, so they're not surgical candidates. So now we have valves that can last 5-10 years that we can deploy through the groin, and this is how it looks like. Once you deploy it, this is how it looks like. That's kind of cool. What we got in cardiology, we're doing this since 2009, so we have perfected the procedure. Now there's like second, third generation valves that are lasting a little longer.
So that image that you just had up there, that has multiple interventions, so you've got a pacemaker.
You can tell this patient has sternotomy, so they have bypass. This is one of the bypass. This is a surgical clips. So I have bypass. So it's I bypass before, then heart is weak, got a defibrillator, and then what happened? Another surgical candidate came with our severe aortic stenosis. So what do we offer him? Look at the chunk of calcium, how calcified the valve is. So taking a surgery, high risk of death with an ejection fraction less than 30%. So we ended up putting artificial valve to the groin. So to show what arrhythmias are, I show you how the heart goes lub dub, and how synchronous the conduction system of the heart is. It fires here, here, and then both sides. So an arrhythmia is a short circuit. The heart goes into a short circuit, and everything starts going berserk, meaning it's firing from different places, and then the Purkinje fibers get confused and get signals from here to here, and the heart, what happens to the heart? It starts going, and when that happens, the blood flow is not going laminarly. Same concept. If blood flow doesn't go through, or it gets stagnant, what happened? It clots. And if it clots, what happened in the next heartbeat? It goes to the brain, and you get a stroke. Especially it's a section of the heart called the left atrial appendage, and it's an outpouching, low flow state that comes out of the left atrium, and that's usually where the clot resides. And you heard patients that are in chronic anticoagulation when they do, you heard about it? Coumadin, Xarelto, Eliquis. Some patients that have arrhythmias, they need to be in long-term anticoagulation. And the ones that have a bleeding stroke, or what have you have a gastric ulcer that bleeds, what do you offer these patients? They were not going to offer. We're like, well, I guess we'll wait till you have a stroke. And now we have something called the Watchman. And the Watchman is now an umbrella that we can go through the groin and go all the way to the left atrial appendage, deploy it and occlude it. So it's a little umbrella right here. And we can actually, this is where clot usually resides, and we actually go in, deploy this here, and he occludes it, and end the story. Here's an example, and then it clots over time. So this is the option. We've been doing this for the last 4 years. Questions? Okay.
So the blood would go through the umbrella?
No, this is an umbrella that deploys. You see this mesh, and it just clots off, and it'll close this. So it stops right here. And it endothelializes. Yeah. And it pretty much occludes this part, it eliminates this part. When patients go to surgery, and they do bypass surgery, you're gonna hear also, yeah, we did a 4 quadruple vessel bypass, and well, in there we ligated the left atrial appendage. If you're doing surgery, surgeons electively, they just get this up and ligate it and close it off. So, because we know eventually they'll develop, arrhythmias over time. Left ventricular assist device. So, you heard about this? So what is this for? We used to have a lot of heart transplants in the 80s and the 90s. For everybody, heart transplants everywhere. So everyone got a transplant. And then what happened, in the late 90s, in the year 2000, less accidents. We invented airbags. Seatbelts became mandatory, so less people were down in car accidents. So we left with there was a very, very sharp decline in heart. So what do? We had to invent something. So we invented the HeartMate, and HeartMate is a left ventricular assist device. It's not a artificial heart, but what it does is it assists. It's a little engine turbine that, when the heart's not able to pump blood enough to the aorta, it sucks blood out, and it actually shifts it and pours it back in the aorta. And today we have HeartMate 1, HeartMate 2. Now we have HeartMate 3, which is now a more magnetic pump. It lasts 10 years. And it's pretty much destination therapy. Some patients are never going to get a heart, so at least it buys you 10 years. In 10 years, we'll see what happens. But it's something that we didn't have before that we have now. And this is the new axial one. And all it does is, you see, it's internal, and only thing that comes out of the body, here out of the belly, it's a little cable, which is for the battery, and you just change the battery packs. You heard about this? Right. So this is actually one of my patients who has it, and he was at dilated cardiomyopathy, so he's still waiting for a transplant.
In 10 years, can you replace it, or is it just over?
Over. Yeah. It's sad because there's patients that have, if the heart is healthy enough, because you have to be anticoagulation in 10 years, there's patients that had another model, usually the heart fails by then. And the good thing is that at least you move up in the chain for heart transplant, but it's pretty much destination therapy. Now what they do is with the new models are 15 years. So the first one lasts 5 years, the HeartMate 2, now that the turbines are better and is magnetic, So the wear and tear, there's no more ball bearing, so it's actually, lasts longer, so we're able to extract at least 15 years.
So it buys you some time to find out.
Buys you time.
To transplant.
Yeah, buys you time.
So this is like shocking the patient's heart, or?
No, this is what it does. It's a little turbine, and what it does is suck the blood out. It's an engine. So it's an engine that sucks blood out and deposits back in the aorta.
So it's like just a blood flow.
Blood flow pump, yeah. It's just a blood flow, right? To help the patient perfuse. Follow me? Question?
How hard is it nowadays to get a heart transplant?
It is very hard. Like that's why we spoke that it's very scarce, and usually you have to be either 3 heart failure admissions, patient has to be already massive medical therapy, hospitalized, intubated. Like usually young patients, we try to save the heart for like postpartum. Usually there's a condition called postpartum cardiomyopathy, which is young girls that have multiple babies, the heart dilates and fails. So save it for the young ones. But it's scarce. It's really, and it goes up by state, and it goes up where you signed off. In Florida, pretty much is Gainesville, University of Miami, and the Cleveland Clinic. That's what we're doing here. Question? Lastly, a heart transplant. So where are we in heart transplant? So we have actually perfected the procedure. We have rejection medications now that I can actually prolong. We can extract 20, 30 years out of a heart. So to show you, can you guys see blood? No one's gonna faint here? Okay. So here's, you can see the difference. Look at this heart, yellow, fat, pale. Barely moving. So these are transplant that are involved with, barely moving. So and look at the difference between now this heart and this heart is all, this is a transplant while we're waiting. Look how nice, red, look at the definition, look at the pump. Look at the difference. This is actually one of the, that was cool. This is actually my last slide, and the reason I want to bring this up because one of the most humbling things about cardiology and as a fellowship, and it happened to me when I became a fellow, if you question faith in God or you don't believe in God or you kind of like, okay, we have the power to do whatever we want, there's nothing more humbling than a heart transplant because other fellows are required to scrub in, and when you take that heart out and you walk away, pretty much throw it in the garbage, and you look back and this patient is dead. This patient has no heart, is hooked to a lung transplant machine. You're harvesting this new heart, and you go back and you put it back into the patient. This patient walks out of the hospital, you follow him through. There's nothing more humbling that that really there's a higher power, helping us through this. And I want to leave it to questions. What I got for you guys. I hope you guys like where we are in cardiology. Any questions? Yeah?
Can we see the last slide again?
This one? I think it's cool because what we do is we take the heart out. We put actually when we take out the heart, we put the outflow. We put it to a machine, and it's called a heart lung machine. What it does is keeps the patient cool and circulating the blood while we harvest the heart, right? And here we have to make sure it works. And the way it works is kind of funny because you put the heart back into the patient, and all you do is you fill it with electrolytes, and you just shock the heart back to life.
What is the thing that's moving up and down over there? It looks kind of like a hammer, yeah.
Remember the corner, the drainage vein, because remember here's the aorta. We pump blood out. It's going to the heart lung machine. It's getting oxygenated, and it's coming back to where blood flow back to the right atrium. So I'm putting it back to the right atrium. But venous flow, the coronary sinus, I have to block it because it will bleed out. I attach that to the patient.
When you put the heart into the patient, you connect this vein to the actual vein?
I connect the aorta to the aorta, and then I connect the vein, the superior and the inferior vena cava.
How do you do it with stitches? Or?
Stitches. Stitches and then the Gort's graft.
So you
Yeah.
It's just tiny.
You teach this little tiny thing all wrap around, and then it's kind of funny because the heart has an internal battery, because what happens to the conduction system? Because when you take the heart out, you rip a piece off. You rip the right atrium, which has the SA node. So you put the new heart in with another SA node. So the new SA node kind of like takes over. Yeah. That's kind of cool. Yes.
So I've seen like a double bypass before.
Yeah.
It's like when they stitch the artery together, it's like automatically, and they unblock the heart. Like it's automatically already like blood tight. How is that possible? It's just stitching.
Through stitching, remember you're stitching tissue with tissue, and you use Proline. You remember you had, that's what when I don't know, you heard when you have surgery, you have internal stitching and external stitches. So you use stitches that are they're Gore-Tex, the graft. So kind of like a little PVC tube, and then you attach it to it, and it doesn't leak. And it's bulletproof, and because as you stitch it up, it grabs on, and then it heals, and it forms a fibrous cap over it. So, good question. That's why one of the bypass that I show, it shows the stitching. I don't know if you saw that so this is what you ask here. It's just stitching. Yeah. And we bypass the blockage. That's why it's important. You can only do this when the arteries, like the pictures that I show you, are 90% blocked, because if it's why you don't fix things that are less than 60%, because it's competitive flow. So you imagine now, if I have a 90% blockage here, there's no blood flow going in, so now I'm going to bypass the blockage, so this is going to now supply distally. But if there was only a 50% blockage here, and I just open this garden hose here, it's going to be backflow. So what's going to happen? It's going to close off. So that's what's important that when we bypass arteries, they have to be 70 or 80% more a block.
How often do you transplant? Like an average?
I would say 1 every 3 months.
Oh, that's quite often.
Yeah, every 3 months. And it happens sporadically. It's, patients, car accident. That's the most common. You get a car accident, and then the license, patient's a donor. You have 4 hours for a heart, for kidneys, 6, 8. Or for a heart, you have 4 hours. You can harvest it like here, and now we can get a little more, like 6 hours out of it. But yeah, that's cool.
So, could you share a little bit more about like the average week? What do you do? A lot of caths and intervention versus showing up at ER to do?
My week goes, so my day starts, I go to 6:30 a.m. To the hospital to see consults. I don't have a nurse practitioner. I get let's say a heart attacks that come overnight, and I get consulted in the morning to kind of evaluate it. 5-10 consults at 7 in the morning. Then after that, 8:30, 9 o'clock, I go to the office where patients are already upset waiting, and see about 30 to 40 patients a day, from arrhythmias, from follow-up cardiac cath, from initial evaluations of chest pain, because a lot is chest pain, but it's not heart, so you have to navigate through protocols to see if it's heart or not related. And then because we have a cath lab in the office, the beauty is that while I'm seeing patients, the cath lab is like, patient's ready. So I just walk in, do my procedure, and then I walk up to the next patient and keep seeing patients through the day. And sometimes, happens in the week, they call you for an emergency pacemaker in the hospital, and you're like, no, you have to walk out of the office, but at least have the patient on the table ready. You can walk in, do the procedure, and come back out. And usually my day ends around like 5 o'clock, 6 o'clock. Then I go to the hospital and kind of finish up, whatever consults they are or procedures, and then go back home in a second job and be a dad. So it's busy. It's busy, but it's very rewarding. One thing about cardiology is that you get immediate results. A patient comes with chest pain, I can do an echocardiogram, I can do a stress test. I can actually tell the patient, this anxiety is not the heart. I have the tools to actually make that assessment and give the patient an answer. So let's do a blood work, and let's predict what it is. So that's the beauty about cardiology, that you give patients answers. And we have the technology today to kind of like get those answers. Your patients still having chest pain, you do an angiogram, you have clean coronary, it's not the heart. Maybe it's the abdomen, maybe it's the stomach, So that's the beauty about this field.
Alright. It's more like personal. How do you manage like being a doctor, but also like your personal life, since like you're so busy?
It's a lot of sacrifice. You know, in the first years I came here 2008, it was rough because I had to get myself known. So you have to do dinners and lectures and go see whatever consults they are and go to speak to the primary doctors. So there's a lot of sacrifice. You know, kind of like you have to risk seeing your children grow. I never did that. You know, I was one of the guys who took my kids everywhere and traveled everywhere and had to put family first. It's a race against time. That's a very good question because it's a lot of sacrifice. Right. And then when you learn through life, and now that I'm 51, to go back and happy that I didn't sacrifice that, because you lose that. You have to put your personal life first, because and family. And you know, only life teaches you in the end that that's what matters. But it's through going through training. It was very sacrifice marriage and time with the wife, because you can't go on vacation. You have to train. You have to pass your boards, and it's a lot of training to get to this. So it's in the end it's rewarding, but it's a lot of sacrifice involved. And that's why I waited to have kids. You know, I didn't want to have them when I was in my 20s in my training, because I wasn't able to spend time with them because I was training. So I waited until I became a cardiologist at 35. So at 34, let me have my kids so I can then enjoy some. Right. So it's a balance that is hard to find, but you have to keep your priorities straight, because life can take you to a different path. Yeah, good question.
This gets to the medicine side, but what's the percentage of cardiologists that are also cardiovascular surgeons on call at multiple hospitals, because that call comes in and there's only so many people?
I would say 20 or 30%. Yeah. Usually now, at this stage in my life, I leave it to the younger guys. We have an intervention in the group, and he does the heart attacks. So now he's in the middle of the night doing it, and I'm like, you know what, I'm too old for that now. So I just make sure it's a heart attack and then call him in, so he comes and put that stent in the middle of the night. Usually, but that's when you're young, that's what you do. You have to get yourself out, the unknown, and you need the experience. So it's like 30-40%. Yeah. In the group that we have, Eliezer Hernandez, who's it's one of his kids go here, so it's him, me, and then two other partners. So we're a group of 4. When I came here first, it was in a group of 8 cardiologists, and then I went on my own, and for my own group 4. Best thing I ever did. You can manage more of your personal time. Questions? Feel free. You can always come by the office if you're free. You guys want to see a cardiac cath, you can scrub in. I have kids, I have residents rotating. It's cool when you see it live, what you can do through fixed to the groin and how the information you can get. It's kind of cool.
Average length of time on that?
The cath? 10 minutes. Yeah. It's funny, it takes more time to get the access to actually do the procedure. But then actually after we take the catheter off that I show rather the groin, you have to hold pressure, for a good 20 minutes, and then the patient has to sit there for 4 hours. Those catheter has French sizes, 4 French, 5 French. So for every French, it's 2 hours. The size, because you go to the artery and you have to make sure that they form a plug. Today also we have devices that we can actually go in and put a plug so the patient can walk out. Also, one thing I didn't mention that we're doing even to the groin, we do now cath through the radio. And that has changed cardiology, because now patient walks in and all he gets is, and you're gonna hear about it, all you get is a little Band-Aid. So now we're fixing everything to the radio. So that's kind of cool.
So is your office in the hospital, or is it?
Actually, it's a tower, right? It's in Wellington Regional, Wellington Regional Hospital? Behind is 4 towers. So one of those towers on the first floor is my
Okay,
office.
so but it's close by the hospital.
Yeah.
So you get your patients through
That's the best. I get a lot of patients actually from primary doctors that they come in and out. And then the good thing is that when you get called for the hospital, you have to drive.
Yeah.
Like I used to be in the office and cover Pans West. I have to drive to Pans West to do a procedure and come here or see a patient. Now I just walk in, see, and quickly go back to the office. And we have nurse practitioners in the office who help us, at least, see patients while we do that. Yeah. Cool. Like it? Fascinating. And you guys walk. I'm gonna leave a lot of the stuff here so you guys can welcome to use it and navigate. I brought pictures also of what coronaries look like, so you guys can have it here too. Thank you for having me. Appreciate it.